Okay, good afternoon, everybody. My name is Greg Carr. I'm going to talk a little bit today about animal models and their potential utility for your programs. A little bit of background on me. So I'm currently a lead investigator at the Lieber Institute for Brain Development at Johns Hopkins. I'm also an associate professor of pharmacology and molecular sciences at the School of Medicine there. And I've sort of made my way into academic drug discovery by way of starting out as really a psychologist who kind of wandered over into neuroscience in graduate school. Did my PhD at Penn, and there I worked on animal models studying comorbid depression and anxiety, and specifically looking at the potential utility of kappa opioid receptors as treatments for comorbid depression and anxiety. As a postdoc, I decided to stick around in psychiatry and made a slight shift over to schizophrenia research as a postdoc at NIMH in Bethesda. And there I really looked into the genetic and environmental risk factors that contribute to cognitive impairment in schizophrenia. We use transgenic mouse models to try to identify ways that these genetic environmental factors modulated cognitive function in animals with an eye toward potential therapeutics in schizophrenia. And so moving up the road to Baltimore and starting the in vivo pharmacology lab at the Lieber Institute, I've continued a lot of this work really focusing on the cognitive impairment associated with schizophrenia and how we can use animal models to potentially improve therapeutic options. And so I'm going to talk today. Thank you to Barb and Mike for inviting me to speak today and giving me this huge topic and 50 or so minutes to go into it. So because of that, I'm going to keep things, I think, at a high level and use some examples, mainly from psychiatry, depression research, to talk about some of the key features that you should consider when you're thinking about whether or not to use an animal model for your work. If you are going to use an animal model, which one? Maybe you'll need to develop one. And so what are the components that go into sort of successful incorporation of animal models into a research program? The focus for this talk is really going to be around in vivo animal models and even sort of tighter focus around in vivo behavioral efficacy models. And that's mainly due to my interest in biases. So just know that there are tons of animal models in terms of in vitro as well as ex vivo models. But for the talk today, I'm going to focus on in vivo models with additional concentration around behavioral assays. So really, I like to start with what I hope you'll get from this talk, if nothing else. So sort of these three learning objectives, which are, first, it's really important to differentiate between an animal model and an assay. And so I'll talk about that difference and why it's important to keep that separate. We'll talk about three types of validity that you can sort of evaluate your models or your model assay combinations to determine their usefulness for you in your work. And then I'll talk about some of what I think are the key features required to select an appropriate animal model. And so these are kind of points that are extremely important for allowing you to sort of translate your work into hopefully successful clinical outcomes. So why, at least in my opinion, are animal models useful and in some instances necessary? So there are in silico and human-based in vitro models that can be used now and can provide valuable information. And so I'm really going to focus on these three components for why I think animal models have utility and what you should be thinking about with them. So the first is really You can increase the knowledge of the pathology and pathogenesis of a disease. You can use animal models to study particular genetic mutations, environmental risk factors that you can potentially incorporate into these models. And that can give you some information, potentially causal information, that you may not be able to get due to lack of access to clinical populations or ethical considerations, experiments you can't do in clinical populations. Sort of once you have what you think is a good model, a valid model, you can then test potential therapeutics for efficacy in the model, or either on a component of what you think the disease is, or on symptoms related to the disease. And then you can also look at sort of toxicity or adverse events associated with these therapeutics, right? And so this is an important thing to know before you go into your clinical trials. And so I'll stop here and say probably the vast majority of work with animal models, particularly in drug discovery, centers around these last 2 points, and really using them to identify or to kind of estimate what you think your therapeutic index will be when you go into the clinic. That being said, really with time constraints, I'm not going to spend much time going through sort of this type of work with animal models. I'm really going to focus on the relationship between the first 2 points, right? So how can you use animal models to increase or improve your knowledge around the pathology and pathogenesis of a disorder? And then also, once you have a model established, how you can use that model to test potential therapeutics and what you're able to learn from that. So really thinking about the early stages of a project and the questions to ask and answer with your animal models. And so the first thing, as I mentioned, that I want everyone to be clear on is the difference between a model or a model system and an assay. And so quite simply, the model here is the animal. So this can be your regular off-the-shelf C57 black 6 mouse from Jackson, right? You've done nothing except order it and put it in a cage in your vivarium. Or you can make more complicated or sophisticated models by incorporating genetic mutations, environmental manipulations. But essentially, it's the animal and any sort of manipulations that you expose that animal to. An assay really is an investigative procedure for assessing the activity of a component of the model, right? So you're either looking at qualitatively or quantitatively measuring some particular target entity. And I have the example here at the bottom, and I'll talk some more about this later in the talk. But if you think about how models are tested in assays, right? If you're looking at a model that may be useful for depression and studying antidepressant activity, fluoxetine increases swimming behavior in C57 black 6 mice, that's the model, in the forced swim test, which is an assay of antidepressant-like activity or potentially depression-like behavior. And so really want to think about how models and assays go together, because as you're building your program, you're going to be multiplexing these, right? So you may use certain models with certain assays, and so you'll want to think about how those fit together. Okay, so I'm going to go a bit more into these 2 topics here. And whenever I think about the use of models or developing a new model, I always try to keep this quote from the statistician George Box in mind, which is, all models are wrong, but some are useful. And this is really important because, right, we're talking about using animals to model human conditions or disorders, right? And there's utility there. I think there's utility, but it's important to keep in mind that they're not the same. And so there are going to be differences that you're unable to there's a gap that you're unable to bridge just because of species-specific differences. So it's really important as you're building models to think about these limitations all the way all the way through your program. So I think the most important thing to consider with animal models is when you're developing it, you want the readout of the model system to match the human readout as closely as possible. And this is, the ideal for a model system. And when the match is not identical, which for pretty much 100% of the case, it's not going to be identical, there are three major types of validity you can use to evaluate the models. And these are face validity, predictive validity, as well as construct validity or mechanistic validity. And so the first is face validity, and it really deals with how much does the model, quote unquote, look, and that's behavior and biomarker outputs, and also sort of the manipulations that you input. So whether it's genetic manipulations, environmental manipulations, how much does it look like the target indication? Right? If you're claiming you're working with a model that you're using for study of depression, what are the similarities? What are the differences between the human condition and your model? Predictive validity really is whether treatments, if there are treatments that are effective in humans, are they effective in the model? Do they produce a change? Construct or mechanistic validity is really the ultimate goal, I think, for model development. And here you're looking to see how well does the underlying biology of the model match that of the disease state, right? And these are not mutually exclusive, as you can probably imagine. If you've got pretty good construct validity, there's a good chance that you're gonna have predictive and face validity as well. So you may be thinking that, I can probably think of other components of validity that may be important. And a lot of people in the field have proposed different structures for this. Here I'm just highlighting some work from Belzing and Lemoine recently, who took the three types of validity that I just described and expanded them a little bit. So you can see the additions that they have here. Other groups have also put their spin on it, but to me, they really come down to the three main, face, predictive, and mechanistic or construct validity. And you can look at it as sort of homological validity, for example, right? Species validity. So you want to make sure that you're in a species that's amenable to whatever it is you're looking for. So for instance, if you happen to be studying pair bonding in social behavior, you may want to study voles, which are known to have form sort of lifelong monogamous pairs, right? So you would need to make sure that those things line up. My view is that kind of falls under sort of face and construct validity. But suffice to say, there are many ways that you can think about this and to sort of operationalize it. And so as you're evaluating your model, I think an important point is that you want to have the simplest model that adequately addresses your research question. And so depending on resources, you can flip this as well. And so, if you're limited in your access to particular models, whether it's for cost reasons or other considerations, you can sometimes flip this and pursue questions that are accessible with the models that you have access, right? And this will help sort of improve your chances of success by making sure that your models are aligned with the questions that you're able to ask and answer. And so with that, there are a few considerations to think about with models and model development, and they're not in particular order here. But, the way I think about this is starting here with cost, right? So model systems are not all the same, and they don't come with the same initial cost. For instance, non-human primate research in general is more expensive than work with rodents, which is generally more expensive than work in Drosophila. And so your choice of a model, again, thinking about the question you're trying to answer, you can play around with the species based off of this particular parameter. Experimental access, and here what I'm really getting at is, for instance, if the question that you're working on, you're trying to get at with this model, requires 1,000 brain samples for you to do the work that you need to do, right? Non-human primates may not be the model system for you, right? You're going to have difficulty getting access to that. And so you'll want to consider what are you able to do? How can you access the material that you need? If you want to study dopamine signaling and you're thinking about how dopamine signaling may be regulating the clinical indication of interest for you, you'll need a model that has a dopaminergic system, right? And so just thinking about those issues. And finally, this kind of goes hand in hand with the other two, are ethical restrictions. So there are just certain types of research that you can't do with certain species. So vertebrates have more protections than the non-vertebrates. USDA-regulated species, more protection than non-USDA, and so on and so forth. And so I'm going to switch here and talk a bit about model validity and sort of determining this in practice. But before I do that, I did want to take a slight detour. And it actually, both Jims this morning touched on something similar here. And so I'm going to talk about building models for particular disease states to help you in developing more than likely a therapeutic. But again, this can also be just sort of gaining additional information about the pathobiology of the disease. But there are certain instances where you may have a sort of a target-based approach where there is a large amount of information, particularly clinical information. There's already clinical proof of concept. So here you may not be trying to build that proof of concept preclinically. And so if you have a program like this, you can set up your animal model so that you're not specifically looking at sort of a disease, modifying a disease, but instead you're looking really to establish a tight PK-PD relationship within your model system, right? And so what you can do with this is if you have sort of in vitro potency data for your model system, you can build in vivo efficacy data in your model system and make these correlations for further clinical development. And I'll use an example from some of our work at Lieber, where we're interested in catecholomethyltransferase. It's an enzyme which metabolizes dopamine. We're interested in looking at inhibitors of this enzyme for cognitive impairment across a few different clinical indications. There's already quite a bit of proof of concept data in the clinical literature. There are compounds that have been used clinically that have safety liability associated with them, so they're really a non-starter for further clinical usage. But we know what these compounds should do in people, and so really what we're trying to do is just choose the best one, the most potent one that we can, and take that one forward. And so here what we've set up is a biomarker assay that, as I mentioned, is sort of disease agnostic, which just allows us to identify the best COMT inhibitor that we can to then take into clinical development. And so here what we've done is, as I said, COMT is involved in metabolizing dopamine. And so we can take a CSF biomarker looking at dopamine metabolites. And so if you block COMT activity, you sort of push dopamine metabolism down this arm, and you end up with the accumulation of the metabolite DOPAC and significant decreases in the metabolite HVA. And so really for us, this is a measure of in vivo target engagement. We can show that the magnitude of biomarker change correlates with the activity of the inhibitor. And so now we can use this to kind of line up compounds based on their COMT inhibition without having sort of a disease model approach here. And so, as I said, this is something that you can do readily if there is good clinical proof of concept and sort of a literature or a body of data that you can lean on to kind of accelerate your program. And so what do you do when you don't have that situation, right? Where you're trying to gain information from your animal model that can be useful for your clinical development. And so there, again, you'll fall back on looking at the types of validity and really trying to evaluate the model that you're working with. And so we'll start here with face validity and a model used in the study of depression called the chronic unpredictable stress or CUS model. I really like this image. I think it does a great job of describing what's going on here. When I was making these slides, my wife was aghast and asked me, "What are you doing to these animals?" I told her, "I'm not doing anything, but these animals are being exposed, in a metaphorical sense to real life." And what I mean by that is one of the major risk factors for depression is chronic, uncontrollable, and unpredictable stress, right? And this exposure is, as I said, an extremely potent risk factor for depression. And the key features are the chronic nature, the unpredictable nature, and the uncontrollable nature, right? Because you can have some components of that. So for instance, I have a chronic stress in that I have an extremely long commute every day up to Baltimore. I live just outside of DC for those who know the area. But it's predictable, and I do it because I love working at Lieber, as my boss Jim's back there, so I need to make sure he heard that. But how do you model this in animals, right? These features, and one way that people have worked on now for over 40 years is this chronic unpredictable stress model, which means that you subject a rodent, usually rat, to a number of generally unpleasant, not terribly, well, I shouldn't say I'm not exposed to it. It might be really bad. But, first here you have wet bedding, right? So you've got an uncomfortable, potentially cold environment that they get exposed to overnight. The next thing you do is you take out the wet bedding, and instead of wet bedding, you just flood the cage floor, right? So now the rat can't sleep sort of as it would like to on the cage bottom. You give it a little pedestal that it can stand on, but can't fall asleep on. So the animal is now exposed to sleep deprivation because every time it falls asleep, it falls over, wakes up. Next day you come in and let's do some unpredictable foot shocks. Follow it up with tilting the cage, now a small cage, no food overnight, no water overnight, right? So you've got a number of these stressors in a row, and what happens after a couple of weeks is you get something that looks like depression, a depression-like phenotype, where you have decreases in sleep behavior even when you haven't flooded the cage and prevented them from falling asleep. You have decreased in motivational behavior, what looks like anhedonia, increases in passive coping responses to additional stressors. And so you've got what looks like potentially a depression-like phenotype that now you can use to either look at neurobiological changes or look at new potential novel therapeutics that may reverse this phenotype. You may have noticed something about this assay that contradicts something I said earlier, which is I said you really like to have the simplest model possible, and this model is in no way simple. And in fact, it's one of the difficulties with this model is it's somewhat finicky and labor intensive. And so people have looked at some of the factors that are unrelated to your what you think are the variables that you're monitoring that can affect this, right? And so I'll talk a bit later about another model that has taken this idea and kind of simplified it, and people are using, I think, to great effect in the field. So think about face validity in a slightly different context. Looking at the marmoset MPTP model of Parkinson's disease. And so for those who aren't familiar, MPTP is a chemical that had been known for a long period of time. There wasn't much done with it until the early 80s when a group of people who thought they were taking a synthetic opioid, and it turned out they were taking a batch that was contaminated with MPTP, and they developed essentially idiopathic Parkinson's almost immediately after taking the drug. And so once researchers figured out that it was the MPTP that was selectively destroying dopaminergic neurons, they thought, oh, this may be something that we can use as an animal model to study this disease. And so here we've got now another sort of compound animal model where you have your species, and I'll talk a bit about why marmosets are particularly good species for this particular model, combined with MPTP administration. And so here, right, so face validity, if you think about the inputs, MPTP is substituting for the genetic and environmental risk factors that lead to Parkinson's in people. And the marmosets are and essentially their behavioral repertoire are substituting for people here. So if you look on the right, you can just see sort of PET imaging showing that you do actually have biomarkers consistent with Parkinson's disease. So this is DAT expression in the brain, and you can see with sort of the destruction of dopaminergic neurons, you lose pretty much all of the DAT expression in the brain here. And so this model has been an extremely useful model for researchers as it reproduces a lot of the motor symptoms as well as the non-motor symptoms found in Parkinson's. So you get decreased locomotor activity, gait abnormalities, fine motor difficulties, as well as cognitive impairment that's associated with disease. So there's nothing unique about marmosets here. If you give MPTP to a mouse, to a rat, to a monkey, another type of monkey, or rhesus, say, you generally will get similar degeneration and some similarities in the behavioral effects. Marmosets, for whatever reason, tend to be more susceptible to the effects. And particularly in comparison to rodents, there's some advantages for using a non-human primate here. One is they spend more time on two legs than rodents do. So you get some of the gait abnormalities that may be masked a bit in rodents. Sort of fine motor skills, grasping and things like that, are much more advanced in marmosets than rodents, and so you can sort of get those fine differences as well. The behavioral repertoire of marmosets is quite a bit more advanced than rodents as well, so you can really dig into the cognitive impairment associated with this model a bit more. And so thinking about, okay, how are you going to build your model? What's the best use for your model system? It's often sort of a combination of these factors, right? The animal species strain, as well as whatever manipulation that you're going to incorporate. And so moving to predictive validity here for a little bit, I'm going to come back to, as I said, the assay I showed at the beginning of the talk, the force swim test. And so here we're going to be looking at rodent models of depression-like behavior and antidepressant-like activity using the force swim test as an assay. And so what are we measuring with the force swim test? Because I think this is really important. For a lot of time and for many researchers, they were looking at this as a model of depression and then antidepressant activity. And I think we need to be a bit more sophisticated in how we think about animal models, and this is actually a really good example of this. And so what are you measuring in the force swim test? Well, it's really a measure of coping behavior in the face of inescapable stress, right? And whether you choose an active or passive coping response, right? So for those who aren't familiar with this test, rodents, rats or mice, there's actually a mouse analog, the tail suspension test, which works under the same sort of parameters. But you place them into a cylinder of water that they're unable to escape from. And so they'll engage in swimming and climbing behavior for a certain amount of time, and then sort of adopt a passive, immobile stance. And so you're looking at active versus passive coping. And so why might this be interesting in the context of depression? Well, it's been known for a long period of time that people with depression tend to adopt passive coping strategies more frequently than those without. And in fact, this risk factor seems to really drive a lot of the connection between stress and diagnosis of depression. So there's something to this link with passive coping. What we know about the task is a lot of models. So the chronic unpredictable stress model that I showed earlier leads to increases in immobility, increases in passive coping. And antidepressants, all those that are on the market, decrease immobility. So they increase climbing and swimming behavior in this task. And so novel compounds that are tested are if they reduce immobility, are said to have antidepressant-like activity. And so I'll stop here for what I think is an important point to kind of talk about, which is, oftentimes behavioral tasks, particularly behavioral tasks, it's important to really think deeply about the interpretation of them. And so I go back actually to a story that one of my advisors in grad school used to always tell, and you may have heard a version of this, which is, he told a story of a researcher who was studying hopping behavior in frogs. And he gave the frog the command. He had trained the frog that when he says jump, the frog jumps. And so he demonstrated this, and he said, well, let's see what happens if I cut one of the legs off. He cuts one of the legs off, the frog jumps. He cuts the other leg off, says jump, the frog doesn't do anything. And so he writes in his notebook, I believe the test subject has lost the ability to hear. Right, and so this is a key thing with animal models, and it's a key thing here with the forced swim test, right? So what I've told you is antidepressants decrease immobility, increase active coping in the task. Can anybody think of what may be a confound for this behavioral readout with this task, or a class of compounds that there you go, right? So psychostimulants, which don't have very much antidepressant-like activity, are a confound in this task. So they also increase activity in the test. And so what you have to do here is incorporate orthogonal assays to really kind of try to isolate the antidepressant-like effects. So if you give these compounds in, say, an open field locomotor activity, antidepressants generally either don't increase activity or in some cases actually can decrease activity on land, which is different from the psychostimulants, which increase activity in both. So part of sort of model interpretation here is making sure you have orthogonal assays set up within your model so that you can isolate the features that are important for the work that you're doing. So interestingly, a critique of the rodent models with the FST has been that antidepressants in the clinic require chronic dosing before you get sort of significant improvement in the syndrome. But antidepressants tend to work after acute dosing in the forced swim test. And so there are a couple things I think to think about here. One of them is, again, getting back to your model system is not your disease. Clinical efficacy is defined very specifically in clinical trials, and it usually has to do with a significant reduction in a global clinical scale of depression, something like a 50% reduction in, say, the HAM-D assessment, right? So that's a very specific definition, and these global scales have subcomponents, right? So there are many behavioral symptoms of depression, and you're looking at a global change. Whereas in the forced swim test, as I mentioned, we're only looking at a small component of the behavioral response. And so what's interesting about clinical administration of antidepressants is some subcomponents of depression, and specifically here I'm talking about psychomotor impairment. So thinking about lack of movement, lack of motivation to move or to engage in activities. These subcomponents can often improve much faster, on the order of 1 to 3 days even after treatment, whereas your actual mood, so your subjective feelings of sadness, take much longer to elevate after treatment. And so why is this potentially important to think about? I go back to one of the grand rounds I attended as a graduate student, and we talked to a patient who had been treated with antidepressants for his depression. He'd had major depressive disorder for a long period of time, and he talked about his treatment and the time before he was treated. So the time before he was treated, he said, for as long as he could remember, he had wanted to commit suicide, but he was unable to because even getting out of bed was a huge ordeal for him. And so planning how he was going to carry it out, going through all of the work that would be required to do it, was something that he couldn't get the motivation, even though he wanted to. And what he said was immediately after he started treatment, his mood hadn't elevated, but the psychomotor impairments were now gone, and he actually attempted suicide. Thankfully, he survived, and he made it through, and he's now successfully treated, and he's still on his treatment. But it makes me think again of what are we measuring with these models, and to keep that in mind when you're using these tests. I started this by saying the forced swim test is a measure of active versus passive coping responses. And unfortunately, suicide is often an active coping response to depressed mood. And so there's been a lot of study around a potential link between antidepressants and increased suicide risk, so much so that a black box warning actually was put on antidepressants for this exactly. Subsequent research has shown that over the course of treatment, antidepressants don't increase suicide risk, but there does appear to be a significant spike among patients in the first 1 to 9 days following treatment. And so what I think is going on here is what we're picking up in the forced swim test, which is this switch from passive coping to active coping before mood has elevated. And so again, thinking about your models and your model assay combinations, what are you actually measuring, and how you can use that information to inform your work and potential translational work. So I'm going to move to construct validity here, and just say that essentially This is an ideal, but not something that you're able to attain in animals. And again, this just gets back to, these species differences, right? The construct is not going to be the same because there is going to be human-specific biology that you can't get around, right? So I'm somewhat envious of my colleagues who work in veterinary medicine. Some of them are able to actually, their experimental system is the quote-unquote clinical system, so they're right there. They may have 100% construct validity, right? But for those of us who work studying human disorders, we don't have that particular luxury. But what we can do is again, think critically about what construct it is we're modeling and what information we can gain from it, right? And I use this example here of C. elegans, which we think of as a model organism, and potential utility for something, say, like looking at signaling with the 5-HT2 family of receptors, right? So there is a C. elegans analog of this family called SER1, and the expression of this receptor is well known. And it's also, its role in a particular behavior is also well documented. So SER1 is known to be critically important for egg-laying behavior in C. elegans. And so, what can you learn here? Well, 5-HT2 receptors are also involved in ovulation in humans. And so thinking about your model systems, right, what can you learn? What question are you asking? What are you trying to model? And which system would be best for that? And so to really think about the connections and the potential there. So where might C. elegans not be particularly helpful, right? If you're looking at sort of hippocampal regulation of working memory, you probably want an animal that has a hippocampus. And so here you may need to use a different model system to really set this up. And you can continue this line even further and think about development of, say, prefrontal cortex, and the significant differences between rodent prefrontal cortex and non-human primate and human prefrontal cortex, and what you're able to study in a rodent, or what you may have to move to non-human primates to actually get a good handle on. So really thinking about, again, those limitations on the model and setting it up so that you're asking and answering a question that's plausible. And so really kind of the last example I'll talk about with construct validity, and this will bring things back to the first model that I laid out, the chronic unpredictable stress model. And here's a model that came out of the chronic unpredictable stress model in many ways. So people looked at that model and thought, that's really complicated. It's very difficult to get reproducibility with it. Any number of factors outside of your control have been shown to change behavior there. And so people thought, is there a simpler model that we can set up to kind of induce the same syndrome and answer the similar questions? And so people have really worked on, and this was pioneered by Olivier Berton and Eric Nestler's group, modifying the resident intruder model and producing a social defeat model with utility for depression. So this model is fairly straightforward. You take a usually C57 black 6 mouse, and you put them down into the cage of a retired CD1 breeder mouse. And so those are important components, right? CD1s tend to be quite a bit larger than C57 mice, and retired breeders tend to be particularly aggressive. And so what happens when the intruder, so the C57, is put in the cage? One, a new environment is stressful for the mouse on its own, but now it comes in contact with a much larger mouse that wants to do physical harm to the C57. So there's a physical confrontation, and then for the rest of the day, there's this partition so that they're not able to come into physical contact, but the C57 has to be in the same location as a mouse that is trying to essentially kill it. And you do this over the course of 10 days with 10 different CD1 mice, and you induce a very similar syndrome to the chronic unpredictable stress model. So you've got anhedonia, decreased social interaction, increased passive coping in the FST and other tasks. And interestingly here, which is different from models that use the FST, you require sort of chronic dosing with antidepressants, with traditional antidepressants, I should say, so your SSRIs mainly, to get reversal of this phenotype. So one of the utilities for this model is you can look at your potentially fast-acting antidepressants to see if you've got any sort of difference in outcome compared to traditional antidepressants. Another really interesting feature of this model is you've got mice who are susceptible to development of the phenotype and those that tend to be resistant. So here we're looking at the social interaction score for mice that go on to develop the phenotype, right? You can see they have a decrease in their social interaction, whereas these so-called resilient mice look just like mice who've never been exposed to the procedure. And so now you can kind of look at potential neurobiological changes or lack of changes that occur following this model. Work from Kafdaraza's lab at Duke has also shown that you can actually predict before exposure who the susceptible mice will be and who the resilient mice will be. So maybe giving you some insight into sort of inborn risk for animals for developing this phenotype. So there are ways that you can sort of use this model now to maybe gain some information on pathobiology of these types of phenotypes, as well as information on therapeutics. And so I'll end here, as I said, with hopefully giving you sort of a broad overview of how to think about animal models and their utility in your program. And again, I'll just touch on the three main points I wanted to convey, which are assays are not models. Models are the animals and the manipulations that you put the animals through, either genetic or environmental. And the assays are the quantitative or qualitative tests that you subject the models to get your measures of interest. So, for instance, PPI is not necessarily a model of schizophrenia, but it's a test of the sensoromotor gating deficits that are present in schizophrenia. And it's a subtle difference, but I think it's important as you're thinking about models. And sort of the three major criteria as I see them for model evaluation. So face validity, predictive validity, and construct validity. And then also kind of the key considerations when you're developing or using a model, which are being very clear on what it is you're trying to model, be as specific as possible, think about those limitations that you may run into. A couple of years ago, I would have said trying to study hallucinations in rodents would be impossible and not worth your time, but Carl Dieseroth is maybe showing that this is tractable in rodents. We'll see. So this is always a moving target, but it's always good to at least know what your parameters are, what your limitations for your model system, and to be clear on that beforehand. And then the other sort of limitations that are in many ways outside of your control, the access, ethical restrictions, and potential costs of doing what you need to do with your models. And so with that, I'll stop and take any questions.
Questions?
Up there, Mike there.
Greg, it strikes me that there's two ways that you can think broadly about models applicable to treatment of neurological or psychiatric disease. And one is to try to think about use of the models for the treatment of the underlying pathophysiology or reversing the disease, if you will. And the other is to look at the symptoms. And so, for example, in Alzheimer's, you might want to try to reverse the progressive neurodegeneration, but you also might think about treating Alzheimer's in terms of improving memory, which has nothing necessarily to do with the underlying pathophysiology. So I wonder if you might be able to comment on that distinction.
Yeah, no, I think that's a great point. And so our work, right? We're looking, to sort of improve options for schizophrenia, and there, we're more or less forced to take a symptom-based approach, and that's because, we could spend all the time trying to build the best model possible, but it comes down to the limitation on the clinical side. We don't know exactly what the pathobiology is for schizophrenia, right? So we can't build a model of that necessarily, and so we have to take a symptom-based approach. So I think that will depend on what it is you're looking to study. Some disorders are more amenable. You may know what the cause is. There are a lot of monogenetic disorders where you know exactly what the cause is. You may not know all of the biology, but that can be studied and that can be determined. And so there you can think about sort of disease-modifying therapies versus symptom-based therapies. But other disorders, you really only have the symptoms to go on because you don't have a solid clinical understanding of what the disease biology is. Yeah.
So I appreciate the semantic
Excuse me, here, take, excuse me, so people can hear you.
Okay. So the semantic distinction between assay and model, I think, is really important in how we think about our experiments. And I run into this a lot when I'm doing in vitro experiments. And I would always butt heads with my PhD advisor about how we said what we were doing. So we look at the blood-nerve barrier, and in vitro, I'm just curious about your thoughts on this. So in vitro, if we grow blood-nerve barrier endothelial cells on a permeable insert and we look at trafficking across and we do all these things, I would call that a model of the blood-nerve barrier in vitro, but it's an assay, and I'm just wondering, what do you think about the distinction between those two things when you're using an in vitro setup?
Yeah, no, that's a good question. The way I would look at that is, sort of those cells that you're using, where are they coming from?
Rat peripheral nerve.
Right, and so to me that is a rat model. There may be sort of better construct validity than some of these in vivo and particularly the behavioral models. But I would look at that as an assay on top of sort of a rat cell model, right? The assay is what you're looking at, whether it's flux or what the readout tends to be, and the system in which you're testing that, to me, is the model.
That makes a lot of sense, because when we're setting it up and we're optimizing co-culture conditions and we use HUVEX, that's a step farther removed. It's not the relevant cell type. And so my brain is thinking lots of thoughts right now. So.
Yeah.
Thank you.
Good.
Hi. I have another question regarding how important do you think that there are the comorbidities in these animal models? Because when I check the literature, at least in stroke, 90% of people are doing 8 to 12 weeks old mice, and stroke happens in the elderly mostly. So how is that in other neurological diseases?
Yeah, no, that's a very important consideration. And again, when you're thinking about building your model, what are you trying to determine, right? So age is something I think a lot of times that is left out for expediency purposes a lot of times. But I think then you need to, again, be clear on what the limitations are of your model, right? What are the components of age that are important for the disease you're studying? Can you incorporate in that model? If not, what are the limitations of your interpretations going to be with whatever it is you're using. I think comorbidities are really important. And my graduate work, we were looking at what we thought was a model of comorbid depression and anxiety, so to speak, in a rat, right? And these rats behaviorally look different than other rats, right? And there was biology behind that as well. And so they responded to antidepressants differently. And it was important for us to look at them in comparison to other model systems. And so it's the same thing there, right? What are you missing by not having sort of the more complex model? But what may you gain by having a simpler model? And those are trade-offs that you'll have to make in your program. But it's a very important point.
Great. Any other questions? Okay, thank you.